Hello, everyone, and welcome. I'm Marcia Mott, the coordinator for UF Health Wellness University. Thank you for joining us today as we learn about this important topic of intimacy and painful intercourse. I'd like to take a moment and introduce you to our speakers, Dr. Jessica Heft and Evette Reed. Dr. Heft is an assistant professor at the University of Florida, Department of Obstetrics and Gynecology, and she's in the Division of Female and Pelvic Medicine and Reconstructive Surgery. Dr. Heft is a Gainesville native and a graduate of the University of Florida. She sees patients in both Gainesville and Summerfield, near the villages. We're also joined by Evette Reed, who is a member of the UF Health Pelvic Floor Rehab team located at Magnolia Park in Gainesville. If you have questions for Dr. Heft or Evette, you can submit written questions at any time using the Q&A button at the bottom of your screen. At the end of the presentation, I'll read your questions anonymously. We're only going to be accepting written questions today, and we're going to try to get through as many questions as possible. Dr. Heft, I'm going to go ahead and turn it over to you now. Thank you so much.
All right. I'm going to share my screen. And I know Marcia's going to tell me if she can't see anything. So thank you all for joining us this morning. Like Marcia said, I'm Jessica Heft. I'm an assistant professor in female pelvic medicine and reconstructive surgery here at UF. I actually think this is the perfect forum for a topic like this. Obviously, discussing painful intercourse can be embarrassing, difficult for some women. So Zoom allows us some anonymity in all of this during the talk and with questions as well. As with any talk in medicine, here's my disclosure slide. I have no conflicts of interest for this discussion. No one's paying me to say anything today. This is really meant to be more informative and educational for all of us. So a little about me. I did my undergraduate studies at University of Florida and then graduate school at Georgetown in Washington, D.C. And I received my MD from the University of South Florida. I did all of my medical training at Vanderbilt University in Nashville, Tennessee, including a 3-year fellowship in female pelvic medicine and reconstructive surgery, which is quite a mouthful. I'm a member of Phi Beta Kappa and AOA honor societies. On a personal level, here are my 2 kiddos, Leah and Caleb, and my husband, Jordan. Jordan and I actually both grew up in Gainesville, and so I love being able to live in this community, work in this community, and help take care of women with urogynecologic issues. So before we really get into the topic today, I want to explain what urogynecology is and why I end up seeing so many patients who experience painful intercourse. Urogynecologists like me are surgical subspecialists who treat pelvic floor disorders. They are sometimes called a female urologist or a specialist in female pelvic medicine and reconstructive surgery. This title is very long. It can be a field that's difficult to describe. It's really not something that was identified as a need until the last 20 years or so. The American Board of Medical Specialties officially approved this subspecialty in 2011. Urogynecologists complete a 4-year residency and then an additional 3 years of fellowship training. And it's essentially a combination of the field of gynecology, which treats the female reproductive system, and urology, which treats the urologic system. Urogynes are specialists in vaginal surgery. And because of this reconstructive aspect of the specialty, it really is a lot of art just as much as science. I say this all the time, but my grandmother always wanted me to be a plastic surgeon. So now I just tell her I'm a plastic surgeon, but for the vagina. I think she leaves out the for the vagina part when she talks to her friends about it. But basically for these reasons, I get a lot of referrals for women who experience pain in the pelvis and including painful intercourse. So our objectives for the talk this morning. I want to answer some common questions about painful intercourse, discuss the importance of quality of life, describe some things that can cause painful intercourse, and then review some possible treatment options. So the medical terminology for painful intercourse is dyspareunia. What is dyspareunia? It comes from the Greek, dys meaning pain, paranos meaning bedfellow. So Dyspareunia, painful intercourse, female sexual pain, those terms are all pretty interchangeable. And those really are describing recurrent or persistent pain with sexual activity. It can be mild to severe and has some significant impact on one's quality of life. Dyspareunia is caused by a wide variety of issues and underlying problems that we will touch on today. So how common are these disorders? Very common. Most studies cite between 10 and 20% of all women will experience dyspareunia. So if you think about a group of 5 women, one of those is likely to suffer from dyspareunia or painful intercourse. To put that in some perspective, erectile dysfunction, which we hear about all the time, affects 1 in 5 men. So think about how commonly we hear about ED treatments, advertisements, commercials, it's everywhere. So I'm hoping today we're able to normalize a little bit some of the thinking around painful intercourse and try to open some of those discussions between patients and medical professionals. So why don't we talk about it? Why don't women bring it up very commonly with their provider? It's so prevalent, we should be hearing about it more. So these are some reasons I hear from patients most frequently about why they don't say anything. It's embarrassing to talk about, patients are busy. I say this a lot, but women spend their whole lives taking care of the people around them. They often don't focus on themselves. Patients often don't really know what's normal, what's not normal. They think maybe it'll get better on its own. There's nothing to do about it. They've never heard of any sort of pelvic floor disorder leading to dyspareunia or something that could be causing their issue. So women are oftentimes very surprised when they find out how common something like this can be. And doctors certainly do not do a good job of asking. So quality of life. Painful intercourse is not life and death. It's not cancer. It's not an emergency. But these issues are things that significantly affect someone's life. It can affect our relationships and our ability to do the things we enjoy, working out, playing with our kids, grandkids, our relationships, obviously. It affects someone's self-esteem, their body image, their stress level. Quality of life is important. Women often put their own issues on the back burner in favor of the people around them. And that really needs to change if we're going to really address dyspareunia, which we just said was 1 in 5 women. We've got to get in front of it and talking about it, asking about it. That needs to be normalized. So what puts a woman at risk for development of dyspareunia or painful intercourse? It's often a lot of factors. So prior tearing or inappropriate healing after childbirth, if someone had an episiotomy or a little cut at time of vaginal delivery, if that did not heal appropriately, that can certainly cause pain. After menopause, women develop more dyspareunia. Genetics can play a role. Prior infections or surgeries of the GYN organs can certainly leave some scar tissue or poor healing, causing dyspareunia. Stress is a huge factor. History of abuse, anxiety, depression, these are all things that can put one at risk for development of dyspareunia. So we're going to talk about some of the causes. It is really difficult to identify one specific cause. Oftentimes it's multifactorial, lots of different things at play. Those range from anatomic problems to complex biopsychosocial issues. Some women, I would say most women, have more than one cause of their pain. And I want to focus on this word biopsychosocial for a second. The female pelvis is unlike any other anatomic structure. This is where women experience deeply personal sexual connections with another person. It's where babies are conceived, grown, delivered into the world. Women as a group are often tasked with a lot of the emotional and mental energy, both at home and at work. And so carrying some of that stress, and often that generates itself in the pelvis, that's very common. I have a lot of patients who are busy supermoms, CEOs, lawyers, doctors. You know, the social butterfly, restaurant owners, they all carry a lot of tension in their pelvic floor. This area carries a lot of memory. So I would be remiss not to mention there are women who have experienced sexual trauma, rape, abuse. All of those previous experiences can lead to chronic pain or dyspareunia. There's a very strong mind-body connection, especially when women when talking about pelvic pain. So physical health and diagnosis of medical conditions is one part of it, but oftentimes we need to address all of the other issues going on at the same time. So we're going to talk about some of the medical causes of painful intercourse, but I want to emphasize again that there's often an underlying psychosocial component. By no means does that mean that the pain is all in someone's head. It can be a prior traumatic experience, the fear of possible pain, the anxiety of how that pain is going to affect their relationship or their health or their self-image. So these lists that we're going to talk about a little bit are by no means comprehensive, but I do want to touch on some of the most common conditions that we see. So we talk about causes of dyspareunia. We're thinking about entry pain, so initial insertion at the opening of the vagina, or deep pain, so deep penetrative pelvic pain. So this is a picture of the vulva. So vulva is the external part, vagina is the internal part. Entry pain can be caused by some skin conditions, including certain infections, eczema, irritation of the skin from an allergy. Could be an allergy to a cleansing product, could be an allergy to the latex that a lot of condoms are made out of. If a woman's had tearing or an episiotomy during childbirth, or they've had pelvic surgery before, that can lead to pain with intercourse, especially at the back part of the vagina towards that opening towards the anus. Lubrication issues are extremely common, and we'll talk about that in a few slides. Vaginismus and vulvodynia are more rare conditions, but they're certainly worth discussing when talking about dyspareunia or painful intercourse. And I often get a lot of patients who come in with questions about those two disorders specifically. So any condition that leads to a decrease in circulating estrogen levels can cause problems with lubrication. This includes after menopause or surgical removal of the ovaries, during breastfeeding, postpartum. Diabetes and some autoimmune conditions also fall into this category. Not enough foreplay. So men and women are just wired very differently. So it's not normal and shouldn't be expected for a woman to become aroused as easily or quickly as it may be for a man. There needs to be some time, some buildup. Typically what's cited is about 10 minutes of lead-in time to penetrative intercourse. That allows the body, the vagina, to become appropriately lubricated. Some medications have a side effect of decreasing circulating estrogen levels and can lead to lubrication issues. Most commonly, those medications are blood pressure medicines, birth control pills, antidepressants, which both decrease circulating levels of estrogen. Some allergy medications can dry out, dry eyes, dry mouth, and unfortunately can dry the vagina. And then some sedatives can decrease the ability of the body to release some of that lubrication. So vaginismus. Despite the willingness to engage in sexual activity, the muscles along the vaginal wall can actually spasm, and that causes pain. So it's this inappropriate involuntary spasm of the vaginal walls. Hypertonic pelvic floor muscles are really the hallmark of vaginismus. Vulvodynia is a more external, persistent burning type pain. So it's on the external female anatomy, on the vulva. This can be a really challenging condition to treat. There's no specific medical cause oftentimes. So we treat these women with a combination of pelvic floor physical therapy, obviously, that's why Evette is here, and potentially along with neurologic medicines that are targeting neuropathic pain, so that burning type pain. So those were all causes of entry pain. Some causes of deep pain with intercourse could be benign gynecologic conditions like endometriosis, fibroids, infections like a yeast infection or sexually transmitted infection, or even a urinary tract infection. Those can be causes of this deep type pain with intercourse. Prior surgery or treatments, we'll get into that a little bit. And another common source of dyspareunia is something that I treat quite commonly. It's pelvic organ prolapse. So prior surgeries or treatment. If a woman's had a hysterectomy before, there's obviously an incision that has had to heal inside the vagina. So if that has not healed appropriately, you can have pain at the very top of the vagina. So that would be that deep penetrative pain. Women that have had chemo or radiation before, part of that, the side effects of those treatments can lead to some dryness and decreased vasculature of the body overall. And the vagina is certainly part of that as well. So pelvic organ prolapse, that's when normal anatomy, which you see in this top left picture, when those things start to fall. So it could be the bladder, it could be the uterus, top of the vagina, the back wall where the rectum is. Prolapse on its own is typically not described as painful. Women think of it more as a bulge or a feeling of fullness, pulling, falling. But during intercourse, that pressure to kind of push things back up can certainly be uncomfortable. So women that feel a and then during intercourse have discomfort, that rings a lot of alarm bells in my mind that this woman probably has prolapse. So we're going to talk about some treatments. When we think about the possible medical causes of dyspareunia, these are some questions to consider. When does the pain occur? So is it all during sex? Is it after intercourse? Where's the pain located? Is it more entry, deep? Does it feel like it's on the outside? How long has the pain been present? Was there some inciting event, like ever since the delivery of my second child, ever since my hysterectomy, ever since I started this new medication? And to think about what type of thing improved the pain. Even if it's just rest, taking it easy, that type of information is very helpful when trying to figure out what's going on and how to treat it. The most important goal in managing painful intercourse is patient education, empowering women with knowledge about what's going on with their body. It'd be silly not to address any issue that comes up with the partner. So it could be a communication issue, couples counseling, psychotherapy can be very helpful. If any underlying medical issues are identified, to treat those. And then include a multidisciplinary approach. There's not going to be a perfect pill that's going to fix everything. It's very different and very unique for many different women. And making sure that we're addressing both the physical health, mental, social, whatever else we need to at the same time, that's what's going to be in the best interest of the patient. Okay, women with dyspareunia often don't get enough sleep. So that can certainly be a factor in stress. Having good sleep hygiene, which means a regular bedtime, limiting screen time, have a routine when you go to bed, all of those things can help with sleep hygiene. I've had a few couples that there was just a lot of anxiety around having intercourse. They had young kids, so putting a lock on the door, that relieved a lot of the stress and anxiety around intercourse. Anything that can be relaxing. So anything that reduces stress, regular exercise, yoga, meditation. Got patients that do acupuncture, has been really helpful for some women. All of those things are a great idea. Like I said, stress is a huge factor in pain. So delegating tasks at work and home can be helpful. Women often just do too much and take on the bulk of the responsibilities. And I cannot overstate how it's not just the physical work, but the mental and emotional energy that's required to do a lot of our daily tasks. So delegating some of that work can be very helpful. So we do know from good studies that there's less dyspareunia, less painful intercourse in new relationships. I would certainly never recommend someone find a new partner just for this. But, couples can make novelty a priority. Reading books or visiting stores that are primarily geared towards something like this is really important. It's not embarrassing, and it can be very, very, very helpful. Also, avoiding potential irritants or allergies. Strong perfumes, detergents, cotton underwear should solely be worn, especially women with some of that external type pain, because there could be an allergy or just a little bit of an irritation from something that's not cotton. So treatments really depend on the underlying cause. Lubrication issues are extremely common. A lot of over-the-counter lubrication products are actually alcohol-based. I would stay away from those things. You can read on the description of the product what it's actually based in. Water or oil-based are probably preferred. Those products can just be very irritating, very drying, and can make the problem worse. My preferred thing to recommend for patients with lubrication issues is coconut oil. So the same thing you buy at Publix. It's hypoallergenic, it's natural, it's very well tolerated, and it's pretty similar to what your body would produce normally. Because we know that low levels of circulating estrogen can cause dryness issues, it may be worth thinking about an estrogen replacement. Might not be an oral estrogen replacement, but something topical like an estrogen cream can help build the vaginal tissues, make them a little bit thicker, more lubricated, and can make some of that a little bit more normal. So that might be something worth talking to your provider about. Evette is obviously going to be talking about pelvic floor physical therapy a lot, but if I could spend an hour talking about how helpful pelvic floor PT can be, I can't emphasize it enough. These sessions with trained professionals who just help patients reestablish control over their pelvic floor conditions, especially in pain, that can be life-changing. It's all about understanding your body and the signals that it's sending you, and then working through any of those abnormalities. Women's pelvic health, especially around intercourse, has been a very taboo subject and something that's really difficult for women and providers to talk about. But as we touched on earlier, it's extremely important. And so oftentimes there's just a lack of education or knowledge about what's normal, not normal. And so talking to these women who specialize in pelvic floor physical therapy, who are experts, they've seen it all, they deal with pain, they're very sensitive to all of those things. They're not going to do anything that's not going to make someone feel comfortable. It can be very, very helpful just to gain that knowledge, gain some tips and tricks, relaxation techniques, all of that. But I will leave all of that to Evette because it's a great topic. And then surgery we usually reserve for most severe cases. It's certainly not for everyone. The last thing we want to do is operate on someone who's already having pain unless we know it's really going to help the pain. So typically women that have had poorly healed scars from prior surgery or after vaginal delivery, can revise that scar and make it a little bit more normal. Trigger point injections are actually injections into the muscles. I do not do that in the clinic. It's done in the operating room under a little bit of IV sedation for comfort, because you certainly don't want to be putting a needle in something that's already sensitive. But I will inject those muscles with potentially some lidocaine, some numbing agents, a steroid that can help with inflammation, or even Botox. So the same way Botox is used other parts of the body to paralyze muscles to get rid of wrinkles, we would use it in those pelvic floor muscles to temporarily paralyze parts of them so that they can be relaxed. And most often trigger point injections are done in combination with physical therapy. So you're getting a little bit of an kickstart of relaxing those muscles by paralyzing them. And then physical therapy comes in and helps reestablish your connection over those muscles. So some of the take-home points. Painful intercourse is common and treatable. There are often multiple underlying factors. And I would be remiss again to not mention that strong social component, psychological component. Women that have had pain once, if you're anticipating the pain, the muscles are going to get tighter, and then you are going to have pain. So it's almost a self-fulfilling prophecy in some ways. So breaking that cycle, establishing control over those muscles, control over your body, that can be really difficult. I would say most women that have a medical cause of dyspareunia have some sort of pelvic muscle tightness, which again is going to worsen the pain because the body's natural response to pain is to tighten. And so if you're having pain and you tighten and then it's worse, we can't just treat the medical problem that initially caused it. We've got to treat the muscles too. Behavioral changes like we described before, sleep, relaxation techniques, communication with your partner, therapy, couples counseling, all of those things should not be underplayed. And then talk to your healthcare provider early. Painful intercourse is not normal. We know it affects a woman's quality of life and her self-image, and those downstream effects are significant. So there are so many things that we can do to help with this type of issue that really is individualized. So there's nothing wrong with talking to your healthcare provider. They may not feel super comfortable hearing about it, but they can at least get you to the right person, get you to somebody who is comfortable about it. You don't have to go into some crazy detail with your, male primary care physician who you've been seeing for 30 years, who also takes care of your husband. You just mention, hey, I've had some dryness or, pain with intercourse, and they will refer you to the right person. So just thinking back to quality of life, women and doctors just don't do a good job of talking about these types of issues. We've talked about how common dyspareunia is. I guarantee, if not yourself, there are women in your life that are struggling with this, really in silence. They're embarrassed. And like I said, there are things that we can do. I hope our talk this morning really helps everyone understand a little bit more about dyspareunia, and just like erectile dysfunction for men, that we can just normalize it, normalize treatments, normalize talking about it, because it's important. I want to eliminate some of the taboo and shame around this type of issue. So thank you all. I'm gonna stop sharing my screen and hand things over to Evette.
Hi, everybody. I'm gonna get my screen up and running.
That looks great, Evette.
Okay, great. I was having a little trouble with this earlier, so hi, my name's Evette Dobby Reed. I'm a physical therapist, and I work in the pelvic health section at Magnolia Park. We've got 6 pelvic therapists at Magnolia Park. We also have 1 pelvic therapist at the Medical Plaza location, where they typically see more oncology patients. However, they may have some space for seeing patients without an oncology diagnosis with pelvic issues, depending on how busy the schedule is there. So I am going to follow up from what Dr. Heft was talking about and talk about basically how physical therapy can help painful intercourse. Just to give you a little background about myself, I've been a physical therapist for 25 years. A little hesitant to say over here in Gainesville, but I did go to LSU, graduated in '95 from the physical therapy program. And I have been working exclusively with pelvic and abdominal issues for the last 10 years. Before that, I was working in home health. I saw an opportunity to work one-on-one with patients and missed very much doing manual therapy. And in my first years as a PT, I worked in a chronic pain program, treated mostly spine issues, cervical, lumbar spine, that type of thing. I have 2 children. I have a son that's 14 and a daughter that is 11. And that's a big part of how I ended up interested in moving into pelvic health. After I delivered my daughter, I had a vaginal delivery for my daughter's delivery and started having pain with intercourse and just had never experienced that. And an opportunity came up for a position when she was just at 1 year old. So that changed my course of practice quite a bit. My son was delivered via C-section, so I have some scar tissue related to that. And I also struggled with urinary tract infections from a very early age and ended up with some painful episodes, not necessarily related to an infection, but would just continue to have some bladder urgency and frequency. And so I've learned a lot about how to help those issues. So in helping other people, I've been able to help myself. So it's been rewarding in many ways. So like Dr. Heft was saying, a lot of people don't want to talk about having painful intercourse. So it's kind of a taboo topic. A lot of people will, talk about how they went for physical therapy for a shoulder problem. But if they're going for pelvic therapy and they're coming down our hallway, they might feel like they're a little bit embarrassed for other people to know that they're seeing a pelvic therapist. And really and truly, it's just one other part of our body that can end up with problems from a physical therapy standpoint, the musculoskeletal and visceral mobility. So it's hopefully over time will be more acceptable to talk about. This is just another slide just showing how embarrassed people are oftentimes talking about painful intercourse. And there's a speculum because when we're talking about pain with intercourse, women who struggle with pain with intercourse often will have pain during a pelvic exam, or they may not be able to wear tampons. So pain with insertion is an issue. If you're not able to tolerate a pelvic exam, that's going to affect being able to have a thorough annual exam. So what are some of the causes for painful intercourse? When we're looking at it from a physical therapy standpoint, it is often that the patient will have tightness in their pelvic floor muscles. Some of the signs that someone may have issues with tightness in their pelvic floor muscles besides pain would be they may have some problems with bladder. They may have trouble starting their flow of urination. They could have a need to urinate often. The normal range for frequency of urination would be about every 3 hours during the day, and you should be able to sleep through the night or get up only once a night to urinate. So if you're finding yourself going more frequently and you're drinking somewhere along the lines of 8 cups of water a day, then you are going to the bathroom just a bit more often. And that's something that would be related to oftentimes pelvic floor tightness, sometimes weakness, or some irritation. Of course, it could be an infection as well. So you always want to go and see your physician first and have a thorough checkup. Sometimes not being able to empty your bladder completely. Also having trouble with your bowels. So you could have trouble with a complete elimination. You could have some constipation issues or pain with your bowel movements. And another topic that Dr. Heft was mentioning that I didn't put on this slide is prolapse. So that sometimes will, those tissues will get in the way and they will actually be pinched or hit way too early with deep penetration. The pelvic floor muscles have a role with sexual function. So we're talking about pain and that tightness in the pelvic floor muscles.
Evette, I'm going to interrupt you really quick. For some reason, we just see your very first slide, and I'm sorry I didn't catch that earlier.
Oh.
Trying to get through some of the questions. So we're still on your home slide.
Yeah, I see that. I don't know why it's not pulling over. Let me see. let me come off of this. Let me just stop sharing for just a second, maybe do it again.
Yeah. And I can promise the audience, we practiced this about 15 times and it worked perfectly. But you know, it's 2021, so these kind of things happen.
Let's see. Let me stop that again. Let's see if this one's better.
All right, we see the first slide right now. Try change.
Yeah. Why it's not clicking through. The only how's that?
We see the double screen right now.
Okay. Oh, hey, I don't. How's that?
Same thing, still two screens.
Yeah.
There we go. We have one screen now and it's the second slide.
Yeah.
Yep, there we go.
Okay.
It's just different than that. That's okay. Yeah, just ignore that.
Okay. All right.
All right, we're back to where we need to be.
So there's the cat. And here's the other cat. So you'll forgive me, I'll have to look a little bit to the side here, but okay. So we were on the slide talking about pelvic floor function and having pain with intercourse and sexual dysfunction. So I was saying that oftentimes we're thinking right now about painful intercourse and there can be tightness in the pelvic floor, but also there can be issues if there's weakness in the pelvic floor, and that can affect the ability to have an orgasm. So sometimes weakness in the pelvic floor is going to correlate with intensity of orgasm. We already talked about pain with tampon. So Dr. Heft did mention there are some diagnoses. The word dyspareunia is what we use when we talk about pain with intercourse. There are some other terms that you might hear when you see your physician. One of them is levator ani syndrome. So there is a significant amount of tension in the pelvic floor muscles. The deep pelvic floor muscles are often termed levator ani group. Another term is proctalgia fugax. That is often more related to rectal pain, where there is a spasm in the portion of the sphincter that will happen spontaneously. But oftentimes people that are struggling with that issue have tightness in the pelvic floor and may also be having trouble with painful intercourse. Coccydynia is pain in the tailbone. Many people who have had an injury to their tailbone will often end up with some pain with intercourse. Fibers of the pelvic floor muscle connect to the tailbone and sacrum. So anything that jars those structures and connections of those muscles, and if they are not in the proper position or there's been some trauma and inflammation, can affect that entire pelvic floor and end up causing some pain with intercourse. Other diagnoses, Dr. Heft mentioned vaginismus, vulvodynia, that's pain in the vulvar area, anismus, pain near the anus, vestibulitis in the vestibule, which is a specific location in the vulvar area, can have some inflammation and irritation and pain. Pudendal neuralgia is irritation of a specific nerve, the pudendal nerve. And oftentimes it can happen from some compression, perhaps from prolonged sitting or injury, oftentimes with heavy weights, a squatting position. And it makes the pudendal nerve areas will be very tender, sometimes a constant burning sensation, and that's going to impair your ability to have intercourse without pain. Most of these diagnoses can also be used with men. So men do have pelvic pain issues as well. So I don't want anyone to think that this is only a pelvic pain being only a female issue. And again, we've already talked about dyspareunia and dysmenorrhea. Many women who struggle with pain with their periods can also have difficulty with pain with intercourse. So the statistics listed here are similar to what Dr. Heft was mentioning. Chronic pelvic pain has a range of anywhere from 6 to 27% of the general female population. Dyspareunia, 2 to 21%. This is from a few different studies. And then pain with your period, painful menstruation, 16 to 81%. Dr. Heft also had some nice slides talking about how when we're having pain with intercourse, it can spill over into multiple facets of our lives. So it can affect your self-esteem. It is going to oftentimes affect your relationship with your partner as you work through those issues. People can feel hopeless. It can affect their mental state when they're at work. And in some cases, especially with severe chronic pain issues, people can end up in worst case scenarios being suicidal. So it's very important to talk to your physician about these issues with pain. There are many things that can be done, of course, with medication, sending you to pelvic floor therapy, also recommending some counselors to work through some of these emotional issues. So it is not normal to have pain with your period or with intercourse. It is very common and some people just accept it. However, it is not normal and there are many things that can be done to help. Here's some more information on why does it happen. For trauma, we talked about perhaps like sexual abuse, emotional trauma, whenever we're going through times of stress, and that could be something that started back in childhood. We oftentimes hold a lot of tension, and that would also be holding tension in the pelvic floor muscles. And you might notice it maybe neck tension. The same thing happens in the pelvic floor. And so as a protective mechanism, we might have that tension to protect ourselves from emotional issues. Also, if we are suffering with pain, we will have tension as a guarding effect. Sexual trauma is going to involve emotional trauma, and sexual trauma can also have physical damage to structures and tearing. Radiation therapy, so if someone's had any kind of pelvic radiation, there's some scarring unique to radiation therapy. Surgeries, like Dr. Heft talked about, you can end up with connections of the organs that are on the other side of the scar becoming adherent. Also, the scar tissue itself can intertwine with some of the nerves, and it can also just be less mobile and then pull through other structures. So when you're having intercourse, there is a need for some elasticity and mobility in those tissues. So if there's scarring and that area isn't moving, it's going to pull on other areas and potentially cause issues there. And the interesting thing from a physical therapy standpoint is even things when you look at your general posture, if there's malalignment of the lumbar spine, it could be the pelvic. You could have like an SI joint dysfunction where you could have a torsion and that rotation. I brought a little pelvic model. So like if the pelvis is rotated, it will actually cause a torsion through the musculature and the viscera that are inside, and that can affect the function of everything that's inside here too. Hip issues, we're looking at this pelvic model, and you can see here we've got the socket part of the hip joint here, and you can see here how close these pelvic floor muscles are to the hip joint. So you see that there's really not a lot of space. So one thing that's in dysfunction is going to cause its neighbors to have issues. And oftentimes what muscles will do is tighten up in a protective response. When we have an imbalance of pressures, so if we have like COPD, we might be coughing a lot, asthma, if we have lots of high impact activities like running, jumping, all of those will put pressure on the pelvic floor, and there can begin to be imbalances in the forces there. And also endometriosis, past infections, just like Dr. Heft was saying, vaginal yeast infections, urinary tract infections, especially recurrent infections. There's ongoing inflammation, ongoing healing, and the structures in that area will have a certain amount of scar tissue formation in the healing events, and also tension and tightness from that protection for the pain issues. And sexually transmitted infections, chlamydia, gonorrhea cause pelvic inflammatory disease and lots of scarring inside of the pelvic cavity. So yeah, I think that covers most of those. So I've already talked a bit about how physical therapy relates to these issues, but when you come in for a physical therapy evaluation, we have a pretty extensive questionnaire. We do go through asking questions about your bladder and bowel function, in addition to finding out what's going on with intercourse. We also want to know if it's initial penetration pain, is it deep penetration pain, is it specific to a certain position that you're in? And also sometimes you may not have pain during intercourse, but you may suffer with pain after intercourse. How long does that pain last? And you could have both. Some women may have pain for 1 or 2 days after having intercourse. Some people, pain goes away as soon as they stop. And that gives us some information about what might be involved in the structures that we can work on. We also look at your range of motion. We look at your back and your hip range of motion, because all of those muscles connect to your pelvis, and that's going to affect the function of those muscles and organs. We look at your strength. That would be abdominal, back, hip strength, but also pelvic floor strength. We palpate with our hands externally, so we will palpate your abdominal and pelvic organs, the muscles surrounding the hips and the back, and then we do an internal assessment, a vaginal assessment, so that we can feel what tissues are restricted, what's painful, the strength of those muscles, and we also do an external assessment as well to see if there's that tissue irritation. Occasionally we do a rectal assessment. It's not that we do all of that in one treatment, but there are some structures, like when it has to do with the tailbone or maybe on the back side of the cervix, we can sometimes get to some of those structures more easily rectally. So this talks a little more about the importance of an internal assessment so that we can really feel what's going on. This is a picture of looking at the pelvic floor muscles. If you made a slice just across, but right in the pelvis, and scooping out the organs and just looking down at the bowl of the pelvic floor muscles and some of the hip rotators. So just to give you an idea of some of the structures that we work on when we're treating. A lot of what we do is education, talking to you about things that could be contributing to the pain, some changes that you might be able to make, talking to you about meditation, relaxation, some breathing exercises, all to help you begin to relax some of the tension in the pelvic floor. That general objective evaluation I talked about, looking at your back and your hips, Do you need to have stretches that seem more like traditional physical therapy to address the tightness in those muscles? Are the joints not in the proper alignment? So we help to get the alignment better by doing joint mobilizations. We use myofascial release or soft tissue mobilization to help with those muscles, visceral mobilization or visceral manipulation to help with the abdominal and pelvic viscera. Craniosacral therapy is a very gentle therapy that we use when needed, when we see issues there. We also do scar tissue release. That would be external scars and internal scars. And there's several different techniques that can be used for that type of tissue mobilization. Just depends on what we're finding, what would be the best approach. These are just some pictures of one of the therapists doing some of the soft tissue work that we do. We like to usually be skin on skin so that we can really feel what's going on. So pelvic floor muscle relaxation, we teach you awareness of the pelvic floor, what it feels like to tighten it and what it feels like to relax. One of the easiest things for people to tune into is when you sit down on the toilet to urinate, there is a moment that you let go of the pelvic floor. So we have a baseline tension in our pelvic floor because it's a postural muscle. So when we go to urinate, we want to let that tension go so that the portion of the pelvic floor that helps as a sphincter to close down the urethra can open up. And it also facilitates a reflex that causes the bladder to contract. But when you get a feel for what that pelvic floor drop is, you learn that's what it feels like when the pelvic floor relaxes. And we don't want to hold an excessive amount of tension in our pelvic floor all of the time. There's a certain amount there to support our organs, but when we're clenching and holding, we've got to remind ourselves, just like you would to have good posture, remind yourself to relax that pelvic floor. We also use biofeedback. I talked about just meditation and breathing. This is a picture of a computer that has a biofeedback program. When we use biofeedback, we either use very small little sticky electrodes that we just place right on the outside of the anus. You don't feel anything. It's not a stimulation or electrostimulation. It is actually something that's reading the electrical impulses, and it can show you on the screen whenever you're contracting and relaxing. A more effective way of looking at that is using a vaginal or a rectal probe. Those do cost a little bit, about $40 or $50. We rarely end up needing to use something like that because we just use the biofeedback as a tool. Sometimes men, not at all for some patients, because we can give you feedback with our palpation. You can also use a mirror to see when you're tightening and relaxing. That's about the cheapest way to go about it, and it is quite effective. But using the biofeedback machine is just one part of what we do. And once you see what's happening, then you can, if you're struggling to feel it, it just gives you a little additional information. So some people just need that little bit. This is just what a printout of contractions and relaxations of the pelvic floor might look like for a biofeedback machine. I wanted to talk a little bit about lubricants. You definitely want to discuss this with your physician, but I am in absolute agreement with Dr. Heft. I recommend coconut oil all the time. I tell people to just scoop a bit out with a clean spoon into a separate container. You can leave it in the bedroom and just take out what you need for that time. Don't go double dipping in the container. And you want to put a towel down because it does stain. And you may want to put a panty liner in your underwear after you've used it. It's quite soothing if you've got some external irritation sometimes too. So it's not just used for intercourse as a lubricant. A very popular one as well is something called Uberlube. It is silicone based, but it doesn't have parabens or preservatives in it. So it doesn't tend to be very irritating. Then there's also Desert Harvest. If you go online to their website, desertharvest.com, it's an aloe-based natural lubricant. They do claim that it would help with irritation, and I have heard good things about that as well from patients. I do tell patients not to use jellies or gels. The thick consistencies tend to get like glummed up while you're having intercourse, and things get stickier. So that, very well-known KY jelly is that same consistency. KY makes a liquid. I have nothing against KY in general. It's just that the gels are not going to be good for someone with painful intercourse. Carlson's vitamin E suppositories are just some little suppositories, look like a small vitamin E capsule that you can insert vaginally when you go to bed at night, and it just helps like general lubrication. So if you're having a lot of dryness, usually postmenopausal, that's a really good and natural product. So you may still need to use a little bit of something when you have intercourse, but it does help just the general health of the tissues. And with more moisture, oftentimes you'll have improved elasticity of those tissues. Again, you do need to talk to your physician about the lubricants, but this is just from my experience working with patients. So one of the things that we often recommend for patients with pain with intercourse is using vaginal dilators. This is a way that you can work on yourself in between treatments, and you can get yourself better quicker. They come oftentimes in a set of anywhere from 3 up to 5 or 6 sizes, where you slowly move up in size. The set that's pictured here, the gray device over to the left, is a handle. It's like a popsicle stick, and you just attach the dilator on top, and it makes it a little bit easier to reach as you insert it. And you would just put some lubricant on it, and you want to insert it and relax like in a reclined position. So you don't want to be holding tension, so you want to relax. And usually 5 or 10 minutes, 3 times a week, up to 7 times a week. For people who are a little bit more sensitive, have more pain going on or pain afterwards, 3 times a week is usually enough. And when you're ready to move up to the next size, you may need to stretch just a little bit with the smaller size by just pressing it, trying it in a few different directions, like you're going around in a clock, before you move up to that larger size. And when you are ready for the larger size, you may want to spend about 5 minutes with the smaller size, and then move up to the larger size in that same session, rather than just starting off with a larger size the next time. There's a few websites that are listed here that have different types of dilators. Soul Source is a silicone dilator, so they're a little bit softer, but they are more expensive, but they are very nice. I brought one example with me. Again, they come in different sizes. I usually don't care for this type of a shape. It's a little bit more difficult if you're having initial penetration pain. The ones that are a little more like a cone shape that's pictured is going to be a little bit easier to insert. And these devices are best for initial penetration pain. Or if you just feel like your partner cannot slide in because things are just too tight. The goal is usually 1 size larger than your partner. And if you're having deep penetration pain, the dilators will go straight to the back or the very end of the vaginal wall, but they don't really get into all of the crevices. There's an entire vaginal vault that almost feels like a square once you get up near the cervix, or if there's a scar from a hysterectomy. And those areas are difficult to get to with a dilator, and oftentimes will need to be addressed either with a physical therapist, or we can also teach your partner how to work on you. Those deep areas are difficult to get to with your own fingers, but if you have a partner that's willing to come in, we can teach the partner what we're doing and help along if you guys practice either with us or whenever you're over at home, and you can come back with feedback and with questions. This is a pelvic wand. I don't know how easy it is to see me right now, but I did bring one. So if you can't see me right now, I can pull it back up in the questions a little bit later. This wand has a longer end on it than the one that's pictured. This one will get a little bit deeper, but sometimes that may not be what someone needs. It would just depend on the patient. I've got some websites listed. The wands actually work best for deep penetration pain. They help to stretch all around the entire bowl. So that vaginal wall should be able to stretch all the way into like the inside of the hip joint, all the way back to the sacrum and the tailbone, almost like if you press on the inside of your cheek. So when those tissues are not moving easily in those directions, you insert the wand just up to the first crook. I recommend you use the rounded part rather than the pointed end. And you just simply turn it, and then you use the outside like a lever, and it will move into the tissues. So you can then ease off of the pressure, turn it, and go into a different direction. We often refer to this type of work as like working in a clock direction, and we will tell patients not to apply a large amount of pressure to what we say is the 12 o'clock position, right where the urethra is. That can irritate the urethra, sometimes cause some spasms, and you'll feel like you have a urinary tract infection. And you would move into these tissues very slowly, and you would listen to your body whenever you're pressing in. You don't want to be in an extreme amount of pain. Some people might say stop at a 3 or a 4. Some people may say a 6 or a 7. I think that the best option is to work with a pelvic floor therapist and work with them on using one of the devices. Once you feel what a pelvic floor treatment is like when we are working manually, you will have a much better idea of what is a safe amount of discomfort. And also you'll learn what it feels like inside your body, and how long we hold and the type of pressures we use. And I think as much as someone might be able to talk and explain it to you, there's nothing like receiving the treatment and learning that way. And you'll feel much more confident when you go home and use these devices. This is one of the best things that's come out recently. This is called an O-nut. And it is a device that you use when you're having deep penetration pain, and you actually slide it on a penis and bring it all the way down to the base of the penis, and it works like a cushion. So it decreases the depth that they can penetrate their female partner. And so it is a positive thing for both partners. And as the deep penetration pain improves, you take one of the O's off. And then as you move along, you just work your way down until you don't have to use it anymore. And I think that it comes with 4 rings. I believe it cost around $50, but I think it's an excellent idea. So that is my presentation for how we use physical therapy to work with pain with intercourse. I think it's a very, we have a private treatment rooms. We work very hard, like Dr. Heft said, to keep it comfortable for the patient. We are quite accustomed to talking about these issues. And I recommend for my patients, if you would like to bring your partner in with you, I think that's great. I think it's good for you both to understand what's going on. And I'm happy to teach your partner how to work with you, so that you guys can work in between sessions and even after you're done with therapy. And as I said in the beginning, we do have 1 therapist at the Medical Plaza, but we have 6 therapists at Magnolia Park. If you're interested in having therapy, you need your physician to write an order for pelvic floor therapy. And it can come from your primary doctor. It doesn't have to come from your gynecologist, but it may be an environment where you feel more comfortable talking about those issues. But anyway, that's the rest of my my presentation. There's my little dog Gumbo, and I'm gonna stop sharing my screen.
All right, that was great. Thank you. I can tell from the questions that we received how important this topic is for everybody out there, and really what a benefit it is. So I'm going to go ahead and first of all, thank you guys both for speaking. I'm going to go ahead and get to some of the questions, and I think you guys can kind of just figure out who's the better person to answer it, or kind of jointly answer some of them as well. Is there anything that is recommended for low testosterone levels in women?
I'll take this question. So testosterone is pretty controversial in women's hormone replacement therapy. So, estrogen, progesterone, those are the female hormones, and testosterone is really more a male hormone. We know there are normal hormonal levels that are seen to decrease throughout a woman's lifetime. But testosterone replacement has not been well studied. The side effects of testosterone. So the good things are it's a steroid, it's an anabolic steroid. You get good muscle tone, you've got increased libido, people feel great on it. But the bad parts of testosterone are increased risk of cardiovascular disease, mood swings, acne, facial hair, a lot of other things that go along with testosterone. So there's no defined safe area of what a woman's testosterone should be. So testosterone replacement is not typically regulated. It's really not something that the FDA as a whole has endorsed. So usually testosterone is given in the form of almost like a pellet for hormone replacement therapy. I would just caution women that are receiving that. I'm sure people have friends that have gotten testosterone, feel great. Yeah, they feel great. But we just don't understand enough about the side effects and what a safe level would be considered. So low testosterone, I'd be careful about that. It may be more of an estrogen level instead.
Okay, thank you. Let's see. I'm postmenopausal and I get severe burning of the vaginal canal during intercourse and vaginal dryness all of the time. What should my solutions be, or what are my next steps?
Yeah, so obviously our talk is really focused today more on painful intercourse, but vaginal dryness all the time goes right along with that. So as opposed to like a lubricant, which is what coconut oil is really geared towards, something like, I think I saw a lot of questions about Prevalence, or there's a new one I think called Reverie that is a hyaluronic acid cream. Those are more moisturizers of the vagina. So those actually recently, there was a study looking at Prevalence in women who have a history of breast cancer and can't do estrogen cream replacement. It actually is pretty helpful for atrophy and for recurrent UTIs. So it's something that I think people in my field are recommending more and more. So Prevalence is certainly a good idea. It's got a little bit of vitamin E in it. It's just more soothing, moisturizing, so more for comfort, but can certainly, as a side effect, improve pain with intercourse as well.
Okay.
Can I add something?
Absolutely, please.
I was just going to say, and as well as working through the moisturizers, there's often a tremendous benefit from coming for physical therapy as well. There's mobility in the tissues that can still be gained. So by working through and doing some of the manual work and looking at anything else that's going on externally, but yeah, I would expect PT to help with that as well.
Okay. We have another question. It says, I have entry problems where it does hurt and sometimes there's bleeding. Not a lot, just a little after intercourse, and the vagina can feel sore. What would my next step be?
I'll answer just a little bit, and then I'm going to give this one to Evette. So my guess would be there's a little scarring along the posterior portion of the vagina, either from prior delivery or surgery. So having a little bit of bleeding could be that little area kind of tears every time and then has to heal, and that can certainly cause pain. So physical therapy and dilation therapy can often be very helpful for that, but I would defer to Evette for that.
Yeah, I agree with what Dr. Heft is saying. Also, some people have scarring in that area from tears that keep happening every time they have intercourse, and they might be very, very small, and you're just seeing a little bit of spotting. But every time you heal from that tearing, you develop a small amount of scarring, which is not a very elastic tissue. And so by working on very slow stretching of those tissues, you can improve the mobility. And so then the idea would be that you would have less tearing whenever you're having intercourse, using an appropriate lubricant, something that works for you, working with a dilator. So yeah.
Okay. So you might have covered this and I might have not quite caught it, but it's a question here, so I'm going to ask it. What kinds of anatomical issues, besides maybe the tearing, could cause entry pains?
So there are some anatomic, like congenital anomalies. So someone who's got maybe a portion of the hymen that's still intact or a vaginal septum, those things are not as common, but would be picked up on pelvic exam.
All right. Next question is, I've seen several doctors regarding my sexual pain during intercourse, and I've been told the best solution is just to keep having intercourse, and eventually my body will adjust and compensate to make intercourse better. The body will learn to lubricate, muscles will loosen, and my mental state will be better. It's very hard to continue to push through with the pain. And I always have pap smears and exams that come out with nothing is abnormal. What's the best way to deal with the pain? Are there numbing creams that can be used? And is it best to take painkillers before intercourse or afterwards?
Oh, I hate this question. It's something I hear all the time, that women are kind of told to just push through and it'll get better. I don't think that that's necessarily true. And I think having control over your body and not having your body be controlling you is really what's most important. There are times that I've prescribed like a lidocaine cream, but those are typically prior to physical therapy. So women will use it and then go to pelvic floor PT so that they can get the most benefit from therapy and from relaxing some of those muscles. The idea of pushing through something like this, it's just not going to happen. So you've got to relax those muscles. It's got to be work on the front end before, you'll actually get some benefit, but that is a super, super common misconception.
Yeah, sounds like a really very appropriate patient to come for physical therapy. If you do have a prescription for lidocaine, I would bring it with you and not necessarily put it on beforehand, because sometimes we want to know what you're feeling, so we get an appreciation for how tender those tissues are. If it were a circumstance, which I have not run into, because I can start extremely slow, and but we're going to work with you like on where you are, and knowing what you're feeling is important. I do know sometimes people do have to use that initially when they're having intercourse, and the hope is that you don't have to continue, because you want it to be pleasurable. You want to be able to feel what's happening, but when you're having pain, that's not how it should be. But I really suspect that pelvic floor PT would be a very good thing for you. And I think if you ask one of your physicians, some physicians don't realize all the things that we can do in pelvic floor, and they may not realize that we have such a large group of pelvic therapists in this area. So.
Yeah, we're pretty fortunate in the Gainesville area to have such a large group. I think at one time it was one of the largest groups in the state, was it?
I think it's one of the largest groups in the country, is what Vicki has said. Yeah.
Wow. Well, so another related question. It makes me so happy that so many women were able to find this webinar and to hopefully get some information and resources. But somebody asked, I had a car accident in 2019 with injuries in my hip. After the accident, I've been struggling with recurrent UTIs, painful intercourse, and I usually bleed during intercourse and have pain. My husband and I have been tested multiple times for STDs, all of them negative. I spoke with my primary care. He mentioned it may be a mechanical issue with friction. Honestly, I'm desperate. I'm 32 years old, no kids. This issue is affecting my relationship with my husband. What would their next steps be, or what can you recommend for them?
Come see me and Evette. It's certainly not normal, and something being triggered by a trauma like that. There can certainly be a neurologic component. You may have had some loss or hypertonicity of the pelvic floor muscles. So it would certainly be a multimodal approach to that type of treatment, because as she's pointed to, she's very young and it's a significant quality of life issue. So yeah, she should see somebody who specializes in this stuff.
Yeah, and all these things, it's covered by your insurance as well, or it's not like you're asking for something that's unheard of. I mean, I think to find out that there's so many people who are having this, and then sometimes even their own physicians are still saying, you'll be fine, just keep trying.
Yeah, I think most women that I see, regardless, whatever pelvic floor issue it is, they come in thinking they're going to shock me. And it's something I've never heard of. It's going to be the weirdest thing I've ever seen. I'm going to be some crazy case report for them. And I'm like, no, I just saw 3 other ladies just like you. So it is not weird in my world. Unfortunately, these things are common, and certainly treatable.
Yeah. I think people are often relieved to know that what they're going through does happen with other people, because they start to think that there's something wrong in their mind rather than something wrong in their body. And so just knowing that you're not alone and that there are people out there who can actually help you is empowering. So,
yeah. Here's another very similar kind of story. Someone said, I was previously seen by a different specialist in another country, and I was recommended to have a baby to get rid of some of the painful intercourse issues, like hormonal imbalances, and tightness. Does that make any sense to you?
No. No, I mean, it's just not, it's not going to treat the source. And honestly, like we talked about, a lot of these problems can be worsened by delivery or tearing or any kind of pelvic floor trauma, which is what, having a baby is. So no, I would treat the underlying issue first. Anyone that has pain having a baby is not a good treatment option.
Yeah, I wouldn't say to elect that as your solution. I have heard from a few patients with endometriosis that they had less pain after a pregnancy, mostly regarding painful periods. The idea being that if there were restrictions related to the endometrial growth that were connecting, say, uterus to the rectum, uterus to the bladder, as that uterus has a slow stretch on it, it can slowly detach some of those bonds. And so when they're finished with the pregnancy and they have their period and their uterus is contracting, there's less pulls and connections. And also it does help to, level out the hormones for a few months, but then they're right back into their cycles with inflammation and endometriosis issues. So that is the time I have heard that, but I certainly don't think that having a pregnancy to address it would be the right move.
Yeah, the normal monthly cycles of up and down with estrogen and progesterone, those can certainly are, stunted completely during pregnancy. You don't have those same types of cycles. So they can reset after delivery, which is, I think, what Evette is talking about. I've seen that with endometriosis patients too. But I would be hesitant to, assume that that's going to make anything better. It could make things worse.
Okay. Another question we have is, how many vitamin E suppositories are recommended at one time? At what IU dosage? And is it safe to use every night into old age?
So vitamin E is very soothing. It's in a lot of the vaginal moisturizers that I mentioned before. There's no strict regulation or guidelines about how to use it, but if I use vitamin E suppositories, typically I'll have women use 100 international units. That's nightly for 2 weeks, sort of a priming period, and then twice a week after that. So again, this is there could be other doctors that do something a little different. These are not things like antibiotics, or there's a typical regimen that's really studied to treat one specific issue. But vitamin E is considered pretty safe and is used in a lot of lubricants and creams in the vagina.
Okay. Can you describe or discuss a little bit more about prolapsing urethra and it causing pain with intercourse?
A prolapsing urethra is pretty uncommon. Most of those women that have a prolapsed urethra, so that's when this is the bladder and the urethra, and that's how you urinate into the world. So the urethra is at the top part of the vagina. If that prolapses, most women have pain all the time, or they have bleeding. So usually what we see more often is like a prolapsing bladder through the vagina, and that can cause pain, but certainly a prolapsing urethra that can cause pain that's treated surgically.
Okay. Where do you start? So some people have asked a couple questions like, where do you start? So today I've seen this and I'm like, okay, I want to get help. Do I start with a physical therapist? Do I start with my primary care doctor? Do I schedule an appointment with someone like Dr. Heft?
I think, and I'll defer to Evette, I think physical therapy is a perfect place to start because those women know the most about all of this. And a lot of the treatments and, behavioral changes, lifestyle changes we talked about should be individually tailored, and not everyone is going to be the same. So your physical therapist has this window of time to talk to you about what they're seeing, what you've been feeling, and what the range of options would be, and they can really tailor it towards you. So if I was pressed to pick one place to start, it can seem overwhelming trying to relax as much as possible. Get to a physical therapist who can walk you through some of the baby steps.
Yeah, I mean, I think it's you're gonna need to have a physician referral to see one of us. So you're going to need to see one of your physicians. And so if you have not seen a specialist and there is something that's going on that may be more serious, if you are seeing a physical therapist, in most cases, we're going to pick up on something's not quite right, or you may not be responding to the therapy as we would expect. And we would talk to you about seeing a specialist or going back to your physician and talking to them about what's going on. So I think that would be the quickest way to sort of get the ball rolling. And but if you feel like time's on your side and you want to see a specialist, that's going to depend largely on the specific issue. But if it's just for like pain with intercourse, I mean, Dr. Heft and the group of physicians that she works with are all pretty knowledgeable. We get lots of referrals from them. So they know about us, which is wonderful. And they know when it's appropriate to send the patient to see us.
Okay. So you need to get a referral to see a physical therapist, and someone like Dr. Heft could make it. Your primary care could make it as well, or your traditional gynecologist or something like that. Am I correct? Okay.
Yeah, urologist, anyone that you might even be seeing a neurologist. Depends on, you could have other diagnoses as well. So,
okay.
And I think when patients ask specifically for pelvic floor physical therapy, it's helpful for doctors too, because we want to be able to help, and they may, not have a big knowledge about painful intercourse, but they still want to get you to the right people. And so if you say, I went to this webinar, or I heard about this, and I think it could be helpful, that takes it off their plate to have to figure out, exactly how to best treat you. And it lets us help you. Doctors just want to help.
Okay. And in follow up to this webinar, I send out an email like thanking you for attending, and it'll have information on there about where to schedule, where the physical therapist, all that information. So if you haven't gathered it or you don't get it by the end of this, don't worry. I'll send that out in the next couple days. So.
And one thing I'd like to add to that is that even if you are at a point where you are going to be having surgery, let's say you're having surgery for prolapse, or maybe you're having a hysterectomy, many of the surgeons here at UF still send a patient to physical therapy before surgery in order to help you do better following surgery, whether it's working on scar tissue or adhesions that are there. And in some cases, that may make the surgery easier for them to perform. And also with prolapse, starting to understand and learn some of the strengthening activities you're going to need to do, some of the positions that help with prolapse, and just prepare yourself better to recover after the surgery more quickly.
Okay. So you mentioned hysterectomy. If you've had a complete hysterectomy, is there any other help for you or things you can do if you can't use estrogen?
So oral, like pill form estrogen, is very different than topical estrogen cream. There are very few women that can't do topical estrogen cream. When you take estrogen as a pill, you have to take large doses. It can affect other organ systems. But when we use estrogen in a cream, it really is just acting locally. So I have some women, even with a history of breast cancer, who we have decided to use vaginal estrogen cream because the amount that gets in your bloodstream is so exceedingly low. And as long as their oncologist is okay with it, oftentimes the benefits outweigh the risks. But if someone, I would never force a hormone on anybody. So if someone's really not comfortable with something like that, Replens is a good option. Trimethoprim jelly is a good option. All those things start to normalize the pH of the vagina, make it more acidic, like it would be premenopausal. Normal bacteria should be able to live in there a little bit more easily, fewer UTIs, less atrophy, less pain.
Okay.
And one other thing I'd like to add about the lubrication, and I understand estrogen, whenever it's low, there can be some issues, but make sure you're drinking enough water. A lot of people are not drinking enough water. And if you don't drink enough water, there's not extra water for things that are less high on the priority list for our bodies. So that's one of the easiest things to just kind of start with. So
Good point. Good reminder. So someone asked a question, and it's the urogynecologist question. We talked about urogynecologists, we've talked about urology, we've talked about gynecology. Can you kind of talk about really quickly the difference? And someone said that they went to see, for some pain that they had, they went to see a urologist, they went to see a gynecologist, and both of them kind of looked at it separately, but nobody really addressed their problem. Like, can you kind of give a little summary of that on how they can get started with that?
Yeah, so medicine, often we work in our little silos. And so if you're a urologist, you just think about the bladder and the urethra and the ureters and the kidney, and that's your focus. And in gynecology, we're focused on the reproductive system. And in colorectal subspecialties, they're just focused on the bowel. But as Evette showed with her pelvis, that was very helpful to kind of visualize everything really just lives together and they're all on top of each other. And so to treat those things in their silos for women especially just doesn't make a lot of sense. If the bladder is starting to fall, that can cause vaginal symptoms when it really is something that's anatomic with the bladder. Infections in one area can cause pain in another area. If you have prolapse or leaking, that can cause constipation issues. So all of these things are interrelated, and treating just one condition at a time often doesn't make sense. So having somebody that kind of looks at all of those things all together, which truly a lot of gynecologists have been doing even before urogynecology was a field, just because they're so commonly running together, is really important to get somebody that's got kind of the global perspective of health, and the interplay of the nerves and muscles and physical therapy into that cannot be understated.
Okay. Thank you. We have a question, and it's an interesting one. Are there any opportunities for support groups among women with these sorts of issues, or any reading materials or anonymous Zoom meetings or anything you could refer to? You think of anything like that? Not sure I've ever seen any anywhere, but.
yeah, I mean, I do believe that there are some out there. I can't give you specifics, but if we have is there going to be an opportunity when you post the information that I might be able to give some links?
I was going to say, yeah, if we have some resources for that, send that to me and I'll get that sent out to the attendees as well.
Yeah, I can look through some of my course manuals. I'm certain that there are some out there. I just can't run them off the top of my head.
Great. And then we've got a lot of questions about seeing a urologist for their husband for erectile dysfunction. And so I kind of mentioned to one of them, I was chatting back and forth with them that, mentioned some of the couple that we had in the Gainesville area, and they wanted to know about some in the villages. So I just kind of want to say that, UF Health in Gainesville is a great urology program, was ranked, I believe, like 11th nationally in the nation for urology programs. So we have a lot of great resources there. We don't have urology in the villages, but are there any resources for urologists in the villages area that either of you are aware of, for men in the audience that might have some issues? Or is that anything that you would commonly talk to the woman about when she came to see you?
Yeah, I saw one person had a question about the issue of double trouble, which I think is hilarious, and I'm definitely going to use that in the future. But the idea of a woman experiencing dryness and then the husband having erectile dysfunction and getting, a super cool, nifty medication to help with that, those are two different people speaking different languages. So to have a appropriate, healthy sexual relationship, you've got to address the couple together. So having the, forgive the term, mechanics on the male side working great, but the woman is not at that level yet. That's just a setup for conflict and problems and worsening of the pain. As far as urologists that are in the villages, so Dr. Moy, who is a female pelvic medicine reconstructive surgeon like myself, who has urology training, he's starting to go more often to the Summerfield office. I'm not sure that he's seeing men there yet, but he is seeing women. And I think, we're trying to get more of a presence there over time, because there's certainly the need for it, and having that subspecialized care is really important.
Okay, great. And how about physical therapy resources in the villages if someone's not interested in traveling to Gainesville? Do you have connections? So if someone sees you in the villages and they want to receive their PT down in that area, do you have resources for that as well?
We don't have anyone in that area. I mean, I actually have a handful of patients right now that drive to Gainesville to be seen. Usually when we start out with physical therapy, we see our patients once a week. So, a lot of people find that that's doable for them, and try to focus on teaching them more of what to do at home. So if it were, coming in for some of the things we're talking about today, I would again strongly encourage you to bring your partner in. Because the more that you can absorb and the more that you can do in between visits is going to be helpful for you to progress more quickly and need less visits, less hands-on visits.
Yeah, I go down to our Summerfield office, usually most Tuesdays I'm down there. So I can tell you the drive really isn't too bad. If I see a patient in the Summerfield office who's got a little bit of prolapse or maybe a little bit of pain or leakage, I send those types of patients to physical therapists in the villages all the time. They treat a wide variety of conditions, and pelvic floor physical therapy is one of those things. If someone's got something that's a little trickier, or especially someone with a lot of pain or pain that's been present for a long time, I really try to get them to our specialty trained pelvic floor physical therapists in Gainesville, just because I think that type of training and that type of eye is really important for those women. And when someone's got pain, you want somebody that knows what they're doing and doesn't do too much too soon. So all of our physical therapists here, all they do is pelvic floor, and specifically women, that's essential.
All right. Well, we have a few more questions, and I'm going to go ahead and address those separately, but I know that you guys have patients you need to get off and see. So I appreciate you guys so much for your time, and this is a very important topic. And I really feel like you guys were able to help make a difference with so many people today. And thank you for your time.
Thank you for putting this together, Marcia, and thank you for coming, Evette. This was great.
Yep. Thank you both. It was fun, and hopefully you guys feel comfortable. And if you need to see us, then reach out. Our email addresses are going to be on the probably on the recorded portion. So if you have any other questions, reach out.
Thank you.